Good morning, everyone, and thank you so much for that lovely introduction. It's very good to be here at the Scold World Forum speaking about this really important topic. So when we talk about global health equity, this is not a new concept if we talk about health equity full stop. But since the murder of George Floyd, since all of the kind of rhetoric about solidarity during the COVID-19 pandemic and the lack of solidarity that we saw specifically when it came to vaccine access and the inequity between the global, well, the quote unquote global north and the global south, you hear that when 1% of low and middle income countries or low income countries specifically were vaccinated, a lot of richer countries are already on their second or third booster. And the question is why? Why is that, right? If there are a lot of businesses and or different sectors that do not really have to prescribe or to abide by kind of a human rights and dignified approach. But when it comes to health, when you have the WHO that says it should be health for all. When we talk about dignified and equitable partnerships when it comes to research and global public health, the question is why do we sometimes not practice what we preach? And the larger question for me, as we go forward with the O'Neill Lancet Commission on Racism and Structural Discrimination in Global Health, is what does this look like in different contexts, and what is the kind of the stream or the line when we talk about discrimination in global health? Is there language that we're actually not using to call one thing something and one thing something else, right? So for the Lancet Commission, what we're looking at is how the manifestation of oppression, of marginalization, of racism, how that manifests in different contexts, but how there's a lot of similarities between communities and between groups or non-dominant groups across countries. And by understanding that, by being able to collect evidence about that, and also to put forward anti-racist strategies and anti-discriminatory policies going forward, that we can work on the specific structures that perpetuate discrimination and lead to poor health outcomes. So looking at casteism and where people are relegated to work and how that affects their health. Looking at kind of redlining and where people have to live and how that affects their health. The Commission really wants to understand all of those different manifestations, from tribalism to racism to indigenous suppression as well. So that's a lot to do, and that's why I'm so excited to be able to moderate this panel today, because we have real life innovators, real life activists and advocates that are working in these areas and understanding how inequity manifests in different ways and through different intersections of identities. So I won't say too much more, and we'll get started with the speakers. But just to say, I'm not going to give bios, but I will just kind of start with some names so you all can know that. We have Aparna Hegde here at the end, who is from the ARMMAN organization. We have Lizzie from Disability. We have Mallika Raghavan from Last Mile Health, and we have Ramatu Jalloh Yorpoi from Partners in Health Sierra Leone. So my first question, ladies, is really about, how did you come onto this work? How did you identify the problem that you're working on? I would love to hear about that, and maybe we'll start with you, Ramatu.
Yeah, good morning all. Yeah, the pathway to my job. My name is Ramatu, first of all, and I want to use this opportunity to appreciate the School World Forum, CHIC, and Partners in Health for giving me the opportunity to be here today. Yeah, I'm a community health worker supervisor, supervising 12 community health workers, supervising 115 patients on a daily basis, where my role is to accompany them to the facility, advocate for them, provide for them psychosocial support, adherence counseling, and also stand for them, because I am the trusted messenger as a community health worker, a voice of the voiceless, an advocate. So yes, my journey started with Partners in Health I was a patient. There I realized how the impact of equitable health is shown to me when I met with partners in health. I was neglected from families and friends due to my status. But with partners in health and the power of the community health workers, hope is given back to me. So I was opportune to be part of the Partners in Health organization as a community health worker. I started as a community health worker, later a supervisor. They empowered me in my educational level. They trained me. They give me all opportunities for me to be here today. So my work is all about how to improve equitable health in the communities. My priorities are that there should be opportunities for others too who are out there. I'm here representing a lot of people who need an answer for this visit, how they will access equitable health. With the intervention of Partners in Health in Sierra Leone, they have started it all. All we need is to be sponsored, empowered more to achieve our goals. Because as a community health workers, we are the front line health workers when it comes to pandemic. While everybody is indoors, we are out there, door to door, searching, encouraging, giving hope to the hopeless, connecting the community people to the facility, empowering them in all their basic needs by advocating for them. So these are the works I do. And I want to appreciate CHIC for connecting me to the world, because they give me that opportunity for my voice to be heard. During the peak of COVID-19, I advocated for PPE for all. With the support of CHIC, we made it. And in 2021, I was awarded as the Heroine of Health with the support of CHIC too. And I'm here today representing community health workers and the communities, not just the health workers, but the community people. So thank you for now.
Ramatu, thank you so much for giving us a bit of insight of why you're doing the work that you're doing. I was wondering if you could tell us a little bit more about, you talked about advocating for personal protective equipment during COVID-19. We know that 70% of people who work in health are women, and a lot of them are those community health workers. Are there specific challenges or barriers that are coming up because women are doing this work, and not having PPE? Quite a few community health workers across the world are not actually even paid or formalized into the health system. But are there specific challenges from a gender aspect?
Yeah. Yes, 75% of the community health workers in my country are women, and most vulnerable, because 75% of these women are the caregivers, at the same time the breadwinners. And being a community health workers without the intervention of Partners in Health is just a volunteer job, without no time limit, working for no time limit, every time, every minute, during the rain, during the sun, the early hours, the darker hours, we are always there. And we believe we have to, because before you ask somebody to do something for you, you have to start it. So I believe as we are there, you guys too will join up. And the only way you can do to support us, to empower us, to fund us, to train us, to educate us, to give us the opportunities to be part of decision making. Because for the gender in my country, we are always at the back as women. They only recognize us when it comes to trouble, like during the peak of the COVID-19 war. 90% of the workers then are the women. And we are just volunteers because we are more exposed. So we have to fight it. Fight it for us to get the stand to protect our families, our friends, our loved ones. So it's just about having interest, empathy. But today, I'm here asking for us to be recognized and for us to be sponsored. What are your contributions? Ask yourself. If you are not infected, you are affected. So as a woman, I believe if the opportunity is given to us, you will find out how powerful a woman is, because we are firm in decision making. When we say we go for it for real. And we are the pillar of the nation's health. Thank you.
Thank you, Ramatu. Thank you very much. So Lizzie, we would love to go on to you and just to learn more about you and the work that you're doing.
Oh, sorry. Thank you. Good morning, everybody. My name is Lizzie Kiama, and I am the founder and managing trustee at Disability Trust. We work out of Kenya, but also in South Sudan and the Gambia. And we specifically work on the sexual reproductive rights of women and girls with disabilities. Your first question was what got me into this work? Mm-hmm. For me, presenting as a disabled woman is an interesting experience because society has certain perceptions around disability, which come from how we are socialized, which come from our cultural norms. And there's a lot of bias that we all hold when it comes to disability. And wanting to exercise your sexuality, your right to reproductive health is difficult when you are in a community that questions your legal capacity to exercise those rights. And so my journey into this work was really informed by my personal experience and the lack of dignity in the healthcare system, the questioning of legal capacity, the increased barriers that are prevalent in the healthcare systems that prevent women with disabilities from truly exercising their human rights. So because I don't know how to sit and wait for solutions, I decided to start a company that worked with private sector to help them think about disability inclusion. And then that kind of morphed into what are the specific ways that women navigate life, access reproductive health, the lack of intention in our policies, in our, in our programming, the way we continuously we continuously invisibilize women with disabilities in our work. We then decided to transition into a nonprofit and work directly with women with disabilities to support them to agitate for change. And through disability, as I said, we started working in Kenya. Kenya is a devolved nation. We have 47 counties. We work in at least 8 counties. We work in 8 counties, about to work in 14 more. But we work through women with disabilities. So we work in the communities with women with disabilities to build their capacity to agitate for change, to hold duty bearers accountable, to, like me, not wait for solutions to come, but to push for them, to increase learnings in the among healthcare workers, because as much as the healthcare sector is clear about medical knowledge, they still come to the work with bias. And this bias has real implications to how people exercise their right to health. And this bias and the stigma and the discrimination in the healthcare system prevents women with disabilities from accessing healthcare. The maternal mortality rates among women with disabilities, for example, are significant. But because of how our society places value, the reality is we don't place as much value on women with disabilities. And so it's easy for those issues to be swept under the rug. So this is how I came into this work, and it's been an interesting 10 years. And yeah, it's exhausting, but it's quite impactful to see more and more women with disabilities standing up and pushing for change. Thanks.
No, that's really brilliant. I think you're really illustrating what intersectionality is, right? When we're thinking about like sexual reproductive health rights and the fight that is happening around the world when it comes to SRHR, but then the added layer and the invisibility that you spoke about. Just something that came into my mind really quickly was Ramatu talking about the lack of women being at the decision-making table when it comes to community health workers. And I was just wondering, when it comes to SRHR work, when you're working with other advocates that believe in the same thing that you do, but they don't have the lived experience of being disabled, what is your organization, or like how does that show up with your organization, and how are you working, to make sure that the voices of women with disabilities is being heard, even within the activism community? Yeah.
Well, for sure, and I think this is common for everybody working in the development sector. Power dynamics are real, and it's a real issue. And for us coming in as disabled women, already the value placements are lower, and there's a hierarchy, And so for us, when we're working with partners, it is critical that we are adding value to the process, and that, at each and every step of the way, that it is a meaningful partnership for both of us. Most of the time what happens is that we should be accepting of whatever is handed to us, because after all, we are being invited to the space and may not have a lot to bring to the table. And that's always a difficult and interesting negotiation that we have to do. So for us, it is the right partners that we get to work with, not just anybody, because then we live in a system that has excluded women with disabilities. If we keep upholding those same values or those same systems, there's no reason for my work to exist. So we have to push back and interrogate and question even the types of partnerships and how they show up, and how we are adding value to the process, and how they are adding value to us as well.
Yeah, thank you so much, Lizzie. That's fantastic. Okay, Mallika, over to you. Just to tell us about yourself. How did you come upon the problem that you are fighting against?
Sure. Great to be here with everyone, and hard act to follow with Ramatu and Lizzie. I have the privilege of working with Last Mile Health as our Deputy Chief Program Officer. I've been working in community health over the last 20 years, but the last 10 years or so where I've been with Last Mile Health, my time started in Liberia during the Ebola epidemic. I'm sure many in this room and watching virtually have also been part of that time. Community health workers were the backbone of fighting the Ebola epidemic. They were trusted by their community. They were the first folks that community members went to when a case was potentially to be suspected or detected. And a lot of those community health workers were working unpaid. They weren't paid, they were volunteering their time, yet they woke up every morning and they went to work. So a big part of how I got into this work was very much through my time at Last Mile Health, but was very much just confirmed by the power of community health workers and the fact that they can save lives in the most remote communities. In terms of the problem or thinking about how we design community health programs, there are two things I kind of want to talk about today. The first is around geography and the second is around gender. When we think about geography, Last Mile Health works in remote and rural communities, and so we define remote and rural as those that are far out of access of, or very far from a health facility. Often community health workers and communities are subject to what we like to call the triple bias. The public sector is unable to prioritize remote communities. The private sector feels like there's no good market potential, and the social sector feels like it's too expensive. This ultimately puts remote and rural communities at an extreme disadvantage. And then it makes it really quite hard for community health workers to then be professionalized, for programs to be institutionalized, for us to prioritize why should a community health worker go and serve a remote community if we are not prioritizing them across the public and private and social sector. And often people make the argument that serving remote communities is expensive per capita, and it can be, but at what expense? That ultimately contributes to inequitable health programs and an inequitable society. And so I think that when we think about remote and rural, we think about everything from electricity to lack of connectivity. These are all things we have to consider when we're designing programs for community health workers. And I think those who have the greatest need for health services are often the ones who least receive it. So I think that the idea of the tyranny of distance and the way we think about remote and rural is quite important when we design programs. I think that Ramatu, you already touched upon this, but gender is an essential consideration as well. Ngozi, you shared that 70% of the health workforce is female. The female health workforce is providing essential health services, reproductive health services, family planning, connecting the community to the health facility. All of these things are central to ensuring that health services are provided in an inclusive way. But right now, community health workers and female community health workers are subsidizing billions of dollars of healthcare. And they're either unpaid or they're paid very poorly. And so I think when we think about gender, we need to think about how much are we relying on a female health workforce and how much of that female health workforce is actually subsidizing our services. So I think those are two things we'll talk about solutions a bit later. But I think it's important to think about geography and gender as two huge contributing factors to the way we think about inequity in healthcare.
That's really helpful way to frame this conversation, thinking about different areas of inequity, and geography and gender definitely being there. But you also talked about kind of this cost versus equity. And when we're designing health systems, I think that comes up a lot, how much things are, and defining the cost, the value of it in monetary terms versus health. So just curious, if we are, how do we advocate for, equitable systems that may be expensive, exactly what you're saying. So what is the work that you're doing, to talk about, how do you even frame that when you're saying this is expensive, but it's equitable and we're reaching people?
Yeah, I think it's a good question. I think, well, is a person living in a really remote community, is their life any less important than someone living in a city? No, we're equal. And so yes, it's more expensive, but there are circumstances as to why people are in remote and rural communities, though some of those are out of our control. And so I think for me it comes down to like a justice argument. Ultimately, we can't place the cost of one human life over another, and that's the equity and the justice argument. I think in terms of work we can do, I think lots of folks in this room, lots of partners, we work to cost community health programs. We talk about the return on investment of a community health worker serving its community. Financing Alliance has done work on like the 10-to-1 return on investment. Investing in community health workers is investing in like improved health outcomes, and ultimately that's like an investment into like our entire society and the well-being of it. So I think we have to look at it from both a justice and equity argument, but we need to look at it from like a cost-effective argument as well.
And it can be both, so that's great.
They can be, yes.
Thank you. Okay, Aparna, over to you, please.
Yeah, so I'm Dr. Aparna Hegde. I am a urogynecologist and the founder of an NGO called ARMMAN that works in maternal child health in India. So I'll speak about how we're using technology to create solutions, but I also want to speak about inequity and how that impacts use of technology to solve inequity, right? So when I was doing my residency in Mumbai in OBGYN, I saw extremely closely how pervasive systemic problems leads to loss of lives of mothers and children, right? And India accounts for 9% of global maternal mortality. 2 children under age 5 die every minute in the country. And in the next 1 hour, 3 women are going to die somewhere in the country, right, in childbirth. And I saw horrific stories day in, India out. Why? Because women were not aware of the risk factors, danger signs, why they needed to access care. And the other end, I saw the health workers not trained to be able to give that kind of care early enough to pick up risk factors, manage in time, and refer in time. And I realized that India's problems are so huge, I had to create solutions which are community-based and designed for scale from day one. So women and children do not end up with such horrific risk factors in the government hospitals. And then when the mobile phone came to India and spread through the country like wildfire, it became very obvious that it was a wonderful tool to reach out to both women and health workers alike with information and training that they needed. And so what ARMMAN did was to create a host of mobile health solutions that on the one hand provide preventive care information, hand-holding women through pregnancy and infancy, so that they can access care, demand care, know the danger signs, know their rights. And on the other hand, we were training health workers at every level of the cadre, the frontline health volunteers, the nurses, the medical officers and specialists, to be able to give the kind of care early enough. And we've reached 35 million women and their children in 20 states of India, and we've trained over 290,000 health workers. And we work with the government of India. But here is where the inequity piece comes in, right? When technology solutions were created, we created them using an equality lens world over. I have a solution, and I give it to the underprivileged, and hope that everybody is going to imbibe it and act on it, right? And there'll be behavioral change. And as we worked further, I realized that no, you cannot think that the underprivileged are one homogeneous group, right? It's not as if you can just paint them with one brush and think that it's all going to be okay. In India especially, there are specific inequity groups. There are populations that are so vulnerable and have such unique vulnerabilities that if we didn't account for them and we did not use technology intentionally to account for these inequities, technology would actually exacerbate the inequities. And we saw this. Yeah, and the thing is that the groups are many, right? I'm talking about, I really don't like the word marginalized. It kind of connotes the, feeling that it's a small proportion of the population. In India, it's significantly large. It's almost 35 to 40% of the population of women we are serving. Just look at the migrant group, 105 crore in India. 105 million women are migrants, right? Look at the numbers, right? So, when we looked at scheduled caste, When you look at scheduled tribes, they are the indigenous population of India. You look at migrant women, young mothers, Muslim women, their access to health care is extremely limited. Just a couple of statistics, right? If you're a scheduled caste woman, your life expectancy is 15 years lesser than the general population, 15 years, right? The infant mortality rate of a Dalit child is 40% more than that of a general population child, right? Just 3 hours away from Mumbai, that's my city, there's a village, I mean, Indian villages are caste constructs, right? They all live in their own subgroups. And it was really stunning for me when I saw this particular village. The indigenous population was living on a hillock away from the main village, and the upper caste would not allow them to build a pakka road. We call it a pakka road, like a paved road from the top of the hillock all the way down to the bottom to access services. And this is a area which gets washed out for 4 months of the year, right? Extreme monsoon rains. So what does it mean for the women and child? Women in an emergency cannot go down for accessing care. They have to be kind of taken in the darkness on makeshift stretchers built with wooden planks. Children do not get access to under 5 services because the health workers don't go up to the top of the hill. There are toilets there, but there is no hygiene and sanitation because there's no running water, right? If you look at the migrant women, right? I mean, they get transported overnight to illegal settlements on the roadside of where they're working, and they have absolutely no access to any pregnancy or infancy care, and no one tracks them. They're not even enrolled into the health services the other place because they may just go back to where they came from. So, I mean, we kept seeing this over and over again, right? So we realized very early on that the solution that you designed, and I'm going to talk about that in the next session. But one other thing I realized was this, is that now you add technology to the piece, right? We talk about creating solutions that will reach everybody. And the only thing we talk about is having ownership of a phone and literacy, digital literacy. But that's not enough. We posit that there are other issues, other domains like privacy, autonomy, agency over the phone. You may have a phone, but you do not have access to it because a woman's access to privacy over the phone is as limited as her access to her own private personal space, and is subject to the same degree of personal surveillance, right? The family members and the husbands are the custodians, the gatekeepers, right? So when I call you, you may have a phone, but the husband may not allow you to pick up the call. The husband is responsible for repair of the phone. You may give a time slot for a call from us, but the husband may not allow that, or the family member may not allow you to have the phone at that time. And we saw that, right? We had a program where we had counseling for mothers with children who had moderate acute malnutrition. 40% of the first call were picked up by husbands who then validated the service and only then allowed us to kind of go ahead, and get the personal number of the woman, right? And then you add to that the fact that women often tend to be passive recipients of mobile health programs, because if their only communication has been with their peers or relatives, they don't have the social skills to communicate with you or to deal with chat bots or to communicate on WhatsApp, right? So this is the whole need for the inequity lens in technology services for maternal child health has really come out strongly for us, and the gender, and the fact that gender underlies the, and intersects with all of these inequity parameters.
No, it's really insightful, and I think the examples that you gave are heartbreaking. The fact that people physically live so far away to make it not even far away, but physically live in places that are barriers to getting access to healthcare, and then the society puts up barriers because of their caste system as well. And you spoke a lot about what ARMMAN does as far as like designing digital solutions that are more equitable to look at the intersectionality of oppression and challenges. And thank you for the insight about marginalization. I'll think about that. It's a good point. Like when you do think about the margins, you think about those that are just falling off instead of huge parts of society that are being oppressed. So I think that's a very good something for us to reflect on. But just to your point about, so you all are looking at kind of the end user experience and ensuring that it increases access for women in those parts of society. But what about the health system, right? Like how if you design an application or a way for like scheduled casts to interact with the health system, but the health system is still the same. The discrimination, the stigma is still there. Are you able to get a better result? Can you tell us a bit about what ARMMAN is doing on the other side?
On the health system side?
Yeah, on the health system.
Well, we're working majorly on health system strengthening, right? I mean, because the good thing about the health system is that the lower rungs, the health workers are, from the same villages as the women we're talking about. Yes, they may not be as marginalized, but that's where I'm talking about the solutions, right? So we're really working very hard in each of the states of the country to ensure that, there is support for the programs from the health system at the lowest level, and that the program is reviewed at every level of the health system. And another thing we're really doing is to have ensure that there's data-driven actions. We expect the health system to collect data. We don't send data back to them to actually tell them that, okay, what is really happening? How can we have data-driven action? So we're working with the health system to ensure that the frontline health volunteer, the nurse, the medical officer, and then the district level, and all of that, and the health officials at the top level have analyzed data that we send based on the programmatic efficiency that we can then use to expect better outcomes and better work on the field and better efficiency, right? Yeah, but I'll talk about the solutions more.
Definitely.
Yeah.
And I'm going to switch things up a little bit because I want to talk about solutions, but I think maybe we get some questions, and within the answers you all talk about the solutions as well, because I'm sure that the audience, we've heard so many important experiences and reflections and the problems that we're really seeing when it comes to just engaging with the health system, which in health is a human right? And there are folks that are unable to, just because of who they are, how they exist, how they worship, who they love, access the health system in ways that other people can. And so I'm really curious to what the audience, the reflection, the reaction that the audience has to what our speakers have told us so far. And then when the speakers are responding, we'll definitely hear more about what the work that you're doing and the solutions that you all have created. Does that work? Yeah? Okay, so open it for Q&A, please. In the back, yeah.
Thanks. I'm Mahadi from Riders for Health. My question is just how the engagement, what is the role of the government in all this? Because as much as the partners are coming together to support, at the end of the day, it is the responsibility of the government to look after the citizens. What are we doing to engage the government to make sure that there's continuity? If good efforts have started, how do we make sure that it continues beyond donor support? Are we empowering the government to be able to take this forward? But at the same time, I see different partners working in the same space. What are we doing to ensure that the collaborations that we have with other partners is avoiding duplication of efforts and also competing for the same sources, for the same funds, doing the same thing, so much that we find some areas are overfunded while some are really underfunded. So I think those are my two questions.
Thank you. We're going to collect a few questions and then we'll come back to the panel. So, right here.
Hi everyone. My question goes to Lizzie. Lizzie, you spoke about the health and health access of women with disabilities. You said a striking sentence, which is that the maternal health outcomes for women with disabilities are poor, and we place a value on this. It will stick with me, that sentence. Now, this is a room full of healthcare people who probably not really aware of this. And so, maternal health outcomes are not the only area where persons with disabilities experience worse outcomes. So I'm just wondering, can you advise everyone here, whether it's being a funder or an implementer of health services, what can we do to be more considerate of the health and health access of persons with disabilities?
Thank you. More questions? Well, maybe we take the lady with the glasses and then this lady here. Okay. Then we can move to the panel.
Thank you so much, the lady with glasses.
Sorry.
So I'm Lenny Bazira. I work with the Community Health Impact Coalition, where our role is really to make professional community health workers the norm worldwide. And I'm so privileged to have met Ramatu in this room. My background, I'm a medical doctor, and I'm hoping there are other health professionals in the room. So my question to Ramatu, and also Lizzie and others, and maybe you can send it back to us, in your work, what support did you get from the other health professionals? Because we've been discussing that we need professionalized community health workers, we need to pay, they need to supply you, we need to make sure you have a career path. But then again, we are mindful that the human resources for health investment is limited. So when you are interacting with the doctors and the nurses who are like your supervisors or the people you refer your clients to, do you feel supported? Do you think if we ask them to advocate for your cause, for the need for you to get paid and supplied like they are, they will actually speak up for you? Because I know we have not heard so much from them. Of course, in addition to what the other person at the back mentioned in terms of the government support, but not just the government in terms of the ministries of health, but others like the public sector, the ministries of defense and the police. I think somebody mentioned the issue of security. You work in rural outreach communities. Who provide the security that you need, especially for the female healthcare workers? As you go about, you wake up at midnight because you received a call from your client. Do you have the security support system to make sure that as you go out, you're protected as well? Thank you.
Thank you. And then just this question here, and then we'll come back to the panel.
Thank you. I'm Jackie Malouf from Beirut, Lebanon, the head of a diabetes organization in Lebanon and the vice president of the Global International Diabetes Federation. I actually would like to see on this lovely panel somebody from the MENA region, because there is a myth that the MENA region countries are very wealthy. Some, yes, but we also have underprivileged countries and countries in ways of development, but way back in the list of developed countries. So this is kind of a call, a little bit of call for action in that regards. And I wanted to mention that it's very important when we talk health to focus on multidisciplinary approach, as we see focus sometimes on specific areas, and of course I work on diabetes, but it's very important because every disease has its toll on other areas of your health, and we all know that. One point I would like to benefit from your experience. How did you get around to make medical doctors understand the value of other healthcare professionals? And I'm not trying to judge in anybody, but we do face that challenge. If we have any course for physicians, nobody wants to take that. It's the I know, you cannot tell me what to do. But we all know that physicians are great, we need them, but they also need to build their capacities and to update their knowledge. So I know there are many things I talked about, but lastly, I want to say thank you, amazing ladies. I'm so sorry I came in late. I was looking for the room. They kept sending me from one side to another. So I don't usually come in late. And thank you so much.
Excellent. Thank you so much for these questions and comments. And there's several, and I'll group them together and go through the panel. But just, I'll take my moderator's privilege and say thanks for bringing up the point about the voices represented here. I think that's a very good point. I work in the MENA region, and I know that as far as when it comes to like these larger conversations, the agendas, even, I do a lot with like pandemic treaty, and I think the MENA region is very underrepresented. And so I think it's good feedback for SCOL and for our partners around the room as well. So thank you for that. I think it might be good to start with the question about the role of government, because I think everyone probably has some feedback and some experience in how your specific organizations, with the work that you're doing, so wanting to hear more about that, but how is that being integrated with the work that is happening at a national level? If you work in a regional level, you can talk about that too. So maybe I think we'll go this way, and since we started this way, so please, Aparna, could you start?
So we work with the government. So we do not believe in creating our own parallel infrastructure. That's not at all cost effective. India does have a very strong public health structure that needs to be supported. There's a shell there, but that really needs to be supported to work better. So all the programs talking about the services to women directly, the voice calling services now that we're going on to multimedia, etc., is our Government of India programs. It's called Kilkari, right? And the other hand, the health workers we train are government health workers. So you talk about frontline health volunteers, the auxiliary nurse midwives of the Government of India, the medical officers working in government hospitals, and the rural specialists working in the tertiary government hospitals. Unless you do that, it's not going to be sustainable. Right? And there are very well-meaning people in the government, but the magnitude is so huge, you need the social sector to support them to do it better, right? And I'll give a small example, right? I mean, every state of the country has a live database of mothers and children, but the data quality is extremely poor. Right, so we work really hard with them, and that's the data we're taking for our services. So we're working really closely with the state governments to improve the data quality, because once the health volunteers know why they're collecting the data, they'll be able to ensure that and how it's going, the analyzed data is going to help them in their work. They improve their data quality services, right? And same thing with when you ensure that at every level the programs are reviewed. And the support for the review, there is a monitoring that is happening better at the government level. Right, so a lot of these efforts need to get done so that the government improves, and it's not that you creating services is parallel. Yeah.
And ARMMAN, is there a demand to work with, like, does the government want to work with you? Are there any challenges with, ensuring that the work that you do, the tech solutions that you have, are incorporated in the existing maternal child health programs?
Yeah, exactly. These digital programs are Government of India digital programs.
Oh, they're government, okay.
Yeah,
okay,
and we call the programs Government of India programs, and we manage them, because it's very difficult for the government to have in-house mHealth experts, right? It's going to be very difficult for them to have expertise in technology, in monitoring, and they get transferred very frequently. They hire officials, so they need technocrats to come in, and social sector organizations like ours to support them to implement those programs. But ultimately, the Government of India programs, and then they're sustainable, and government funds them. Right. So the way we work is that government funds the technology cost, the call cost, and we fund our own staff, because we're not vendors. We support the government in implementing the programs. Yeah.
And Mallika, with Last Mile Health, I know that there are several countries that, you said it yourself, have not formalized or professionalized community health workers. So how does Last Mile Health and the work that you do, how do you ensure that that's part of the government's kind of mandate in health system?
Yeah, so I'll talk about Liberia, where Last Mile Health was founded. Following the Ebola epidemic, former President, Her Excellency President Sirleaf, actually put designing a harmonized national community health worker program on her priority agenda. Before she left her tenure as president, she said, there are 10 things I want to do, and one of them is that partners, government, work together and establish the first ever national community health worker program in Liberia. So I think when we talk about government engagement, it started from the top. There was political prioritization, there was commitment from the highest levels of government. President Sirleaf herself, I think she saw herself during the Ebola epidemic the role that community health workers play. And I think Last Mile Health, with many others in this room, Sheila, you'll remember we had a really deep, long-standing partnership with Partners in Health as well to establish this community health worker program. And so we work in direct partnership with the ministry to have set up the community health worker program in Liberia. And it's been about 8.5 years now, but I think we can proudly say that we have recruited, trained, supervised, equipped, and most importantly, paid community health workers that are serving every community greater than 5 kilometers from a health facility in rural Liberia. And that was not done alone. That was not done just by Last Mile Health. That was not just done by a small coalition of organizations. It was done with the ministry and their commitment. And so I think it's really important to recognize the role that not one single actor can do, but so many together. And I think that was particularly powerful. I also just want to highlight that it's very easy to have momentum on something, especially following the Ebola epidemic. There was just this big window of opportunity. People cared about health workers. People recognized that people in remote and rural areas lacked access to health care. There's lots of research on poor health outcomes, particularly on access to health facilities during times. We saw this during COVID as well. But the community health worker program has continued over the years. Of course, the way that the program is financed is shared between different donors and partners. But more recently, for those who may have been familiar, the Community Health Worker Symposium just happened in Liberia. It was hosted by the ministry. That in itself is a huge commitment to the fact that we care about community health workers, we care about people in remote and rural areas. The president in Liberia has also committed $1.8 million to salaries towards community health worker supervisors. So I think it's showing the movement towards the fact that we can bring access to those that are most needed, and we can do that in partnership with the government.
Liberia is quite exemplary, I think, and it's a credit to, as you said, the government, Last Mile Health, all the community health workers and the partners. I think it also, what you just answered, also answered the kind of the second part of that question about like, how do partners collaborate in a way that is not duplicative and also not missing huge gaps of need as well. So thanks for explaining that. Lizzie, I'm just curious because Mallika talked about, you know, President Sirleaf's kind of 10 priorities, and as soon as she said that, I thought, okay, this is policy making, right? And when it comes to disability, you know, there are some countries that have policies for that, and there's some countries that do not. And so I'm just curious, in your work, working with the government, you said you're in Kenya and you're in 8 counties right now, and I'm not sure if like that policy, I think policy making has devolved to the county level as well. Are there policies that you're working with or you're advocating for to be the backbone of the rights that you are that you're fighting for as well?
So we work in Kenya, we work in South Sudan, and we work in the Gambia. And what is similar in all these contexts is governments will prioritize disability rights based on the ratification of the Convention on the Rights of Persons with Disabilities. So once that has been ratified by a country, then they have momentum to develop subsequent national laws or, you know, national policies that would speak to their strategies. In Kenya, how we work with governments and our approach to the work really focuses on 4 aspects. We focus on the individual. We focus on the woman. We center the woman. We work towards ensuring or building knowledge around inherent human rights, because it is not necessarily how women with disabilities are socialized. With the continuous questioning of legal capacity, we have to reinforce that they have inherent human rights. So that is part of our empowerment program. And then we work with the community. Within the community, also, we work through women with disabilities who are leaders. We believe that if we give them the knowledge and we build their capacity, they can then work with, you know, in Kenya, in the counties, with their governors, with their county, through the county development plans, they can question budgets, they can interrogate accessibility, so they can push back at that level. So it's extremely important for us, because we are one small organization, to be able to create a network that works from a holistic standpoint. So the individual, the community, and then we work on learning or unlearning. And this focuses on healthcare workers. We have a course that we partner with UNFPA, and because of the fact that UNFPA provides value to the Ministry of Health, they listen to the need. So to answer Phyllis's question about, you know, how people can consider, I think because we're talking about inherent human rights, it should not be a consideration. It is a right. And for us, women with disabilities need to know this, and they need to know that it is true so that they can question. Because we are always on the receiving end of charity, of funding, without the need to question. So when we work with healthcare workers, what happens is they begin to now see the gaps in the system. They begin to, you know, interrogate, okay, how does a woman in a wheelchair get up on this bed to deliver a child when it is not, you know, it cannot be lowered, you know? So they now get involved in advocacy at the procurement department level, right? We begin to hear conversations around with, you know, midwives and nurses around sign language interpretation. You know, when a deaf woman comes in or a deaf patient comes in, how are we communicating? And how then do we advocate, you know, for our healthcare center to be able to cater to this woman? So our learning component with healthcare workers focuses on that. And then there's what we found in Kenya and in all, you know, other African countries that we work in, the context is the same, that there's a lack of data. We're not collecting evidence on disability. We do not have disaggregated data, even at the Ministry of Health level. When a patient walks into the healthcare setting, the data that is collected, we don't ask, you know, whether an individual has a disability. We only ask, in Kenya at least, we only ask if they have a disability when it is the case of gender-based violence. This is the only type of data around disability that, you know, is collected, which again speaks to the violence and the association of violence, you know, around disability. So we agitate for that, we advocate for that. You know, we have organizations, our partners, Missing Billion builds also evidence around and knowledge around disability rights and does a lot of, you know, research work around that. But also as partners, what I have found, or what we have found, is that we are comfortable with what we know. So when we build knowledge or when we interrogate, we don't actually interrogate what we don't know. So because we don't know much about disability, we are not investing in learning more. So it's a vicious cycle that keeps, you know, repeating itself. So for us, we think the four, you know, that framework with four key approaches: the individual, the community, the unlearning and the learning, and the building evidence, the data is critical, because it comes from a holistic standpoint. There's no one way to do this work. So at our strategy is at every step of the process, we have people that are speaking, you know, in different ways, speaking the same language with the same goals to advance, you know, reproductive health, and even media. How media and the narrative in the media, how it portrays women with disabilities from a victim standpoint, that they do not have that they are asexual. Not that there's anything wrong with asexuality, but because this is the only narrative that is available, it then informs public awareness. It informs, you know, how we design programs, how we think about policy. So, thank you.
No, thank you so much. Yeah. There are many times I wanted to clap, so thank you. No, I think you talked a lot about power and partnership, and, you know, even though it's appalling to have to use someone's power to just talk about human dignity and human value, I think something that we all can take away from what everyone has said is like the power that we have to make groups more visible and to reinforce the human rights and the dignity within every single person. So I'm taking that away. But Ramatu, over to you. You know, we talked a lot throughout this conversation just now about the need for partners, how we work with government. Mallika talked about how Last Mile Health and Partners in Health have worked together to really raise the visibility and create the platform for community health workers in Liberia. I'm wondering if you can tell us a bit more about Sierra Leone and how that is manifested with working with the government and partners there.
Yeah, in Sierra Leone, I believe the government works with the partners because, for the first place, if the government did not accept the partners, we have no room to establish whatever they want to. And they have been working together to promote health. Like Partners in Health, they are working with the government side by side in whatever implementation they will do. So the government accept them and embrace them. All we need here is more partners for us to for them to advocate more, for us to achieve our goal. But the government in Sierra Leone are always willing to work with partners as long as concerning development of health or about health.
And in Sierra Leone, are community health workers paid? Are they part of the more formalized health system?
Well, the community health workers in Sierra Leone for the government sectors are not paid. I think some of them are on stipend, the active ones, while the community health workers that are supported by partners in health are paid, are encouraged, motivated, and also they empowered us, equipped us in whatever situation or pandemic or on our daily basis activities. They empowered us. So all we are yearning for here is how more partners will come in to empower the government and partners in health, because they have already been there, they have started it, so that the other community health workers from the government will achieve the same opportunities for us to capture our goal. The only pathway here for the equitable health outcome is when partners come and collaborate with the government, partners in health, then we'll achieve all what we are here for. Thank you.
No, thank you, Ramatu. I mean, thank you. So I'm kind of hearing two steps when it comes to the government. One is being open and allowing organizations that you all represent to work with the populations, because like you said, Ramatu, if the door is closed, then that's a huge barrier. But the other step is to what Mallika was talking about, is it actually being part of the governmental system. Otherwise, it's very, what you described, Ramatu, about some healthcare workers or community health workers being paid by partners and others not being paid is an inequitable reality, and can be quite discouraging for the community health workers that are doing the same work but not getting paid. So thank you for that insight. I think, you know, one thing that we want to, well, before I go on, are there any other questions for the panelists? Okay, please go ahead. Okay, we have two. I don't know where the microphone went. Okay, so if we don't mind getting the lady on the left. I think we have probably, yeah, we can probably take 3 more questions and then we'll wrap up. Yeah. Which one? Oh, in the back, okay, all right, thank you. Oh, in the front? Oh, okay, I didn't see, sorry about that.
Thank you very much. I think this is very, very exciting. I've honestly enjoyed listening to the conversations being challenged. So my name is Frida Njogu. I'm a medical doctor, public health practitioner, who has worked in the health system in several countries, including seeing the benefit of, you know, community health workers in HIV, TB, maternal child health, and so on. But currently I work for an organization called ID Insight that provides data and evidence for decision makers. And I'm just wondering, you know, on the one hand, I see the significant underfunding for community health workers and the challenge that governments have in paying that large group of of professionals while they have other competing priorities. I'm not saying that they should not prioritize. I just empathize with governments as they try to make, you know, try to figure out where do we cut to ensure that everybody is adequately compensated for their work. I'm keen to hear what your thoughts are in terms of, so on the other hand, as a data firm, and probably this is something that other data organizations have, we are regularly trying to, you know, get extension workers or distributed folks to work as, you know, regular survey enumerators, so that people who live in their communities, who then make additional income because they work in those communities, they can actually collect regular data and get an alternate source of income. I just want to hear what your thoughts are about that. We've been, you know, trying to talk to a few organizations, trying to see whether community health workers would be the right kind of people for this, because then that would give them an additional source of income that rides on they are already being in those communities. Just keen to hear your thoughts about that. I'm also looking forward to talking to Liz. I think we are both from Nairobi, to see how we can use our data and evidence work to support, including, you know, ensuring that those indicators are included in government tools and so on. But my question was on exploring other ways of income for community health workers. Thank you.
Actually, Can we, there's a gentleman down here who has a question, and actually when we come back there was a question that I missed. It was about no, we're talking about the solutions within the answers, but like the question was about, it was about medical doctors, and I think how working with other health professionals, so we'll go back to that. So please go ahead.
Thank you. My name is Henry van Egen. I represent the Royal Tropical Institute in Amsterdam, which is also the coordinator of ShareNet International. Probably some of you know that. It's probably the largest network on sexual reproductive rights with some 2,000 members. And so I'm interested to hear from you about the ways in which networks can actually help in terms of advocating. And I'd love to hear that as well. And the other thing which came up, which really, maybe it's a strange thought, but I spent the last 4.5 years in the US as a Dutch national, and spent considerable time in Alabama and Mississippi. And the kind of inequities on health outcomes that Mallika was talking about, I've seen them there.
Yeah.
They were no different in terms of age expectancy, sexual reproductive rights, and so on and so forth. So what are the learnings that we can have in a country like the United States from countries from yourself?
I'm actually going to come back to the panel because we only have, I think we only have 10 minutes. Do we have, is it to 11:15? Sorry? 7 minutes? Okay, we're going to, so I apologize. You'll have the panelists to speak to afterwards, so I apologize about that. But I do want to come back to the panelists. Ramatu and Mallika, it would be great if you could reflect on the repurposing of community health workers beyond the health system to get more income outside of just the work that they're doing for community health. And also if you could bring in a response about like how do you work with other medical professionals? Our colleague from Beirut, she talked about, you know, doctors not even sometimes wanting to learn about, you know, allied health professionals. And so how, and I think another colleague talked about, do you get the support that you need from different healthcare professionals? And then you brought up the networks for advocacy, as well as kind of lessons learned about inequity. And I think that it is very important. It goes back to kind of visibility and voices on the panel, that, you know, it is very easy to just talk about the quote unquote global south and low and middle income countries when there's inequity everywhere. And that's something that the commission that I'm leading is really talking about, that is we're looking at communities and not trying to, it's stigma to just say inequity happens in the global south or in poorer countries, right? And it's untrue. So I think it's really interesting to hear how networks support advocacy, and how can the work that you've done, Lizzie and Aparna, the work that you've done, what are some of the lessons that you can kind of apply on a global level? And I had said earlier that we weren't going to do just a session on solutions, so I could get the audience to participate. So if you want to incorporate, yeah, you're welcome to do that. Okay. So Ramatu, did you want to start with the community health workers?
Yeah.
Yeah.
So like the health professionals with the community health workers in my country, we are working together because we are the link. We are linking the community to the facilities. And the people we are linking to the facilities they trust us. So the health professionals automatically give us attention because they believe we are the trusted messengers. So we work very well together, and they listen to us. All the partners in health site, all necessary things the community health workers demand for that patient, they work towards it. Because when we demand, the medical doctor approve. With the approval of the medical doctor, then they submit our request. So you see, we work together hand in hand.
What did you think about, this colleague brought up a point about, you know, it can be difficult to pay community health workers from the ministerial budget because of competing priorities. What about using community health workers to help with, like, I'm not sure, you talked about monitoring, maybe election monitoring or like census surveys. Is that something that has been discussed in Sierra Leone? So kind of non-health activities and paying them for that. Is that something, what do you think about that?
Well, I think for the government side, they might willing to do so, but I think they need empowerment because they identify the works that community health workers do. It's just that maybe they are not well supported or sponsored or well equipped to take care of them. We have uncountable of people who are there identified as community health workers, but they are not active, the government side, because they are not paid. And I think what we need to do here is for the government to, for you guys to at least bring the government in and see how you can empower them to support community health workers, because we only achieve equitable health outcome by empowering community health workers, because we detect early breakout. We should not wait for the breakout to come. We should support, we should strengthen the community health workers, because they will be the first to detect whatever is about to come. But if we just left the governments out, the partner that is sponsoring the community health workers in Sierra Leone for now, which is Partners in Health, they cannot do it alone. They need to be empowered. They need collaboration so that their dream will come true, because they have already started it alone. I think all we need here is to get more partners.
Thanks, Ramatu.
Yep.
I'm going to go to Mallika. Maybe you can just add on the community health worker part about just the different options to support CHWs.
Yeah, I was actually going to just share a little bit about how do you integrate like physicians or other cadres of the health system. And I think it still comes back to like political prioritization and institutionalization of policy. So if you think about designing a program, I try to think about it in that, like, does everyone define the problem the same way? So if we think about like access to care in remote and rural areas, do people at the kind of like community level all the way up to like tertiary hospitals or at the ministry see the problem in the same way, that, you know, people in remote and rural areas lack access to healthcare? And so I think and then after that, if folks kind of align on that, then I think the next piece is like, do you build a coalition, and who's that coalition of supporters and partners that align on that particular problem? And in Liberia, I think where we had found that the program was able to be successful because we built a coalition that wasn't just folks that were, you know, staunch advocates of community health workers, but doctors and physicians and folks from other sectors that could align. And so I think being part of the design and the solution, and then integrating that into like an institutionalized policy, it makes it more real. It makes you more accountable. And I think that's just been this is one small example perhaps of how physicians can be engaged, especially when a new cadre comes in that can feel like it can feel competitive. It can feel, are they taking work away? Are they taking supplies away? But actually, if the system is working together and integrated and it's all under like a policy that you can implement, it makes it a lot easier to hold yourself accountable.
Thank you. And I do, we're coming to the end, and I apologize because I know that there are so many questions, but again, our panelists, our panel speakers will be around afterwards. And I just wanted to, one, just kind of sum up some of the things that I heard. One is there's power in partnership. And there's so many partners here, so many folks that represent the Ministry of Health, community organizations, NGOs, INGOs, and there's opportunities to support. There's a dearth in data. There's need for evidence, you know, to reinforce the policies that we have to make sure that they're being followed. There's a need for awareness within the beneficiary community, but as well as on the healthcare side as well. And then a need to co-create. So I think Aparna gave just a great example of designing systems without the people centered, the people that the systems are supposed to help, not being centered in the designing of it, and how that can be a huge oversight. And so I think there's a lot of opportunities. So please join me in appreciating our speakers today. Thank you so much.